So I think what we'll do now is move on to the next case. Now we're going to go on and talk about an interesting case with hormone receptor positive breast cancer, of course, the most common subset of breast cancer that we all see in the early and late stage setting. And Adam Brufsky is going to talk about a case from his practice and then review some of the data that we use to try and make decisions for patients who have hormone receptor positive breast cancer. And then we'll talk about how this impacts our decision making. Thanks, Adam.
Thanks a lot. So this is a case of estrogen receptor positive breast cancer. And this is a 63-year-old woman who was diagnosed with a 3.5 centimeter right side infiltrating ductal carcinoma. And she actually, as some of her patients do, for whatever reason, refused surgery, refused endocrine therapy, really wanted to do anything, went off and we never saw her for a while. And now she comes back a little more than a year later and her cancer has progressed. It's now 6 centimeters. And we do labs and her livers are normal. But we happen to scan her because she now has T3 disease. And generally in our practice, our cutoff for doing scans on people is probably T3, really what we consider stage 3 and above. So we do it, and she's got a CAT scan that shows 2 liver nodules. The largest is 2 centimeters. We biopsy it, and it's a grade 2. It's not an infiltrating ductal carcinoma. They usually call it poorly differentiated carcinoma. Actually, it was poorly to well. It really wasn't poor. And it was estrogen receptor positive, fairly strong, at about 80%. Progesterone receptors positive, about 50%, and the HER2 is negative. And so at this point, she's obviously staged as metastatic disease. And her performance status, despite all of this, was really good. It was 0. And so, the question really now is what to do with her. And so we have data from the NCCN. Here, the preferred first-line regimens, I think we're all very familiar with, is an aromatase inhibitor with a CDK4/6 inhibitor. And there's really no preference, as you guys can see, to the CDK4/6 inhibitor. I think there are occasions, and I think, some of us would maybe use fulvestrant first, but I think I would basically probably, unless I say fulvestrant for the people who are already on an aromatase inhibitor, but I'll use that with a CDK4/6 inhibitor. I think that other drugs are clearly available. I mean, they still include other drugs without a CDK4/6, but as I'm going to show you in a minute, I think there's emerging survival benefit definitely in the second line with these agents. And then obviously the second line is what they didn't get before. If someone should probably get fulvestrant and a CDK4/6, if they've had AI, and have not had a CDK4/6. We can talk about PI3 kinase mutated tumors. Those are people who've already progressed, I think, through CDK4/6, probably fulvestrant and CDK4/6. There's exemestane and everolimus, and et cetera, other anti-hormonal agents.